Hello and welcome, and thank you everyone for coming tonight. My name's Catherine. I'm a clinical nurse from the Mater Hospital, and I'm working with my colleague, also Catherine, tonight, who's also a nurse at the Mater Refugee Clinic. Thank you everyone that spoke tonight. It was wonderful. First of all, I'd like to introduce you Dr. Rebecca Farley. You've met her. Nice to see you. Esther. Yes, Esther's also one of the nurses with us at the Mater Refugee Clinic. Maria. Oh, she's coming. Oh, there you are. Yeah, no, take your time. Actually, I did want to say, Maria, thank you so much. I really enjoyed that speech, and I just thought it was really interesting what you said, just to look at the person completely from a cultural context and take the whole person into account. So I really, really enjoyed your speech. Thank you. Also, if you wanted to look inside your bags, there are some more information about the G11, some more stories that you might find interesting. Ulrike, where's Ulrike? Hey, how are you? Nice to see you. And then Dragos. Yes, nice to meet you. Okay, so we've got a little hypothetical case study that sometimes is good to put together so people can understand what to do. So we'll start with a book, and she's a 36-year-old widowed mother from South Sudan. She has 4 children, a 15-year-old son, 11-year-old twin boys, and a 7-year-old girl. She's arrived in Australia on a permanent visa 12 months ago, and she came from a refugee camp in Kenya that she had fled to after the death of her husband when she was pregnant with her youngest child. So you can see there's a lot of issues going on there. In the last 6 months, the primary school where her children attend have noticed a worrying pattern of absenteeism with the 7-year-old girl, Rosa. Abuk speaks limited English, and she's attempted to communicate to the school, mainly through her 11-year-old twins, that Rosa is often unwell with headaches and stomach aches. The classroom teacher has expressed concern that Rosa is not progressing well due to the absenteeism, and also when in class she's withdrawn and reluctant to participate in activities. The school has organised a meeting with Abuk, and during the discussion, Abuk discloses that Rosa has always been a very timid child, but since arriving in Australia, it's becoming even more problematic. Her physical complaints are constant, and she also finds it very hard to be separated from her mother. The school encourages Abuk to take Rosa to the GP just to ensure her that her physical needs are addressed. And as I often see, Abuk presents with a vague story, and she's not actually clear what she wants from the GP, but she says she's there just because the teacher has sent her. In the initial appointment, she admits that she has concerns for her family here, especially little Rosa, and also family left behind in Kenya, who are displaced in other neighbouring countries, and that she has little support here.
So I think my role here is to ask you, Rebecca, a very big question. Where do you start? So when they've come to you, what would you look at in terms of physical health and mental health issues?
Thanks, Catherine. When I first read this, my first thought was speak to the school, and I think that that's a point that I would like to make. I think we often kind of work in these silos and don't speak to each other. So I think one of my first steps would be to speak to Abuk about whether she would be happy for me to contact the school so she's not trying to communicate through her twins. From there, I think I would be kind of doing a lot of things sort of simultaneously. As we spoke about earlier, I think this family has obviously experienced trauma, and so that's going to be in the back of my mind. And I guess when I look at this presentation, I would be thinking that that's probably playing a very significant part. Having said that, there are obviously also some physical issues here that we need to address around the headaches and the stomach pains, and again that is likely to be related to the history of trauma. And I guess as I start to sort of look into those things through a really thorough history and examination, I think I would also be starting to try and really gently explore with the family the possibility that we might not find kind of a physical cause for these things, and that there might be something this potentially might be related to that history of trauma. I guess I would just say that I would be really hesitant to kind of investigate, over-investigate, and I think we do that sometimes, and people get really hopeful that we're sort of going to find something. I think we just need to start to really align expectations right from the outset around what we might be able to find. And I guess just I have to say as well that it would be an opportunity as well to make sure that health assessment had been done and that we'd done all of the appropriate screening for that child as well, and that we'd, all the immunisations are up to date, that kind of thing.
Thanks, Rebecca. I think it's important not to go in guns blazing and make them not come back. Esther, that story is probably very familiar to you. Yes. Is there a role for the practice nurse or refugee health nurse in engaging a book? And how would you work with a book in the GP practice?
So I think, first of all, I'd try to chase up any documentation, any previous nursing assessment that's been done, just to find out a full history on on her journey here, and just any past history that she has. I think it's just when she initially comes in, as Rebecca said before, you'd rather build trust with the family as much as you possibly can. So you wouldn't want to delve straight into a lot of different things or delve into asking too much about referrals and stuff like that. But initially you're kind of building that rapport with the family, and that's one of the most important things. And then going into determining whether we need a paediatric input, so paediatrician input, developmental assessment, and then maybe later on cognitive assessments and referrals. But yeah, I think initially that's what we would do, and then we'd look further with other visits as they come in and following up and stuff. It is going to take a lot of time, so we wouldn't rush into anything.
So, Amy, do you think you would get involved at some stage if a referral went to you?
Yes, definitely. I imagine, this is a very common presentation referral that we receive as well, and it's likely to come at various points, so it might be sort of early on, or as both Rebecca and Esther have said, it might take a bit of time, and then that referral would come our way. But it's absolutely a young person that we would engage with. And I guess it's also in terms of the type of engagement we might have. So it might be in that individual work as well, but it also might be in terms of helping to provide support to the school around how do they understand and work with trauma, and the use of interpreters, and we can help support that process as well. There might be groups that she's suitable to come to as well, and then maybe even providing some support to mum as well. But yes, definitely.
Thanks, Amy. Ulrike, would Kim's be able to accept this referral, and is it an option for the family?
So just imagine we would get the referral from the school right now. Most likely all other services would have been involved already. So that's something important to keep in mind. So would there be a referral in place for Kim's? Yes, there would be. Would we be the right service at this point of time? That's in question. We would do an initial assessment, which wouldn't be a comprehensive assessment, but an assessment to ascertain what services are involved so far and what needs to be done and when is the right time. It's really important for a family like that to have a multi-systemic approach with good timing and very thoughtful collaboration with other services. So we would have the first assessment, and most likely just hearing about the presentation of Rosa, she may have separation anxiety. Has she anxiety herself? That's another question. It may be contextual to high maternal stress when Mum was pregnant with Rosa, ongoing stress in the camp, and then ongoing stress in settlement. And as research shows, to have families missing in the home country creates probably one of the most stressors for our refugees. So in all that context, most likely we would accept the referral, but we would strongly consider, are there other services which need to be involved? Are there other services which would be better placed? And is there a place for liaison with other services to have an interagency meeting to cooperate and collaborate a good, timely intervention? Would Rosa show high levels of anxiety? Yes, it would be very important for her to be seen by child and youth mental health to see if she needs medical support and anxiety treatment. However, by listening at this case scenario, we most likely would collaborate with other services to have a look at developmental and cognitive development. As we know, trauma and developmental problems coexist quite heavily. So, and by the look, QPASTT would probably be a great service for mum to be supported, and Rosa's condition probably would improve if mum's condition would be improving. Yeah. It's complex, many levels. Yeah.
Great, thank you. So obviously Rosa's condition is potentially escalating, and maybe it would be affecting the broader family to a certain extent, because I know as a mother with a child that you can't, sort of help, you feel a bit helpless and you start to get a bit down yourself. So it may end up a referral to a psychiatrist.
Hi. So there's a couple of things I've sort of noticed, and one is that a book is possibly using maybe an acceptable way of an entry into getting some assistance through her children. It's a fairly common presentation, so we want to be looking at, are there problems in the children themselves, but is she trying to get access to support in an appropriate, in a socially okay way for her. And what we talked about before, as in trauma presenting in the body, and there's intergenerational trauma as well. So it's very conceivable that her daughter is experiencing effects of trauma and anxiety, and that's expressing in her body, but also that a book is presenting, she's passive, she doesn't know why she's come along. Well, when clients say that, you have to take many, many active steps to show up at an appointment. So it does imply some agreement and willingness on the client's part to turn up at a set time and a set place. So, you'd be thinking there's something that she does want, but I don't think talking about seeing a psychiatrist at this particular stage is the right way to go. Acknowledging that she may actually have some mental, psychological distress, emotional distress that she wants to recognise. She's just testing the water to see how safe it is, what people's responses are going to be like, and going through her child and the issues of, separation anxiety. What's reinforcing? What does she do when the child's sick? What are the consequences for the child having abdominal pain? Does the child get to stay home? Does the child get to be with mum? Does mum get some anxiety allayed because the child's not separated from her? Are there other benefits? Sometimes symptoms are a way of getting some kind of needs met. So I would probably be talking with the GP
about my way of understanding what could be going on, providing the GP with some support if she's seeing other agencies like, you know, a practice nurse or, you know, an NGO. I'd be pretty happy to talk to them and get some insights and give some advice at this stage, but I don't think it's helpful at this stage because she's fairly reluctant still to acknowledge that that's a mental health problem, but keeping it in the back of your mind, allowing her to explore it more when she's ready and providing sort of stage care, more appropriate levels of support as she's requesting is, I think, a better way to go.
Okay, so we're dialing it back a bit from the psychiatrist. Dragos, do you think you might have a role in this now, if the referral came to you?
Yes, there are a few probably scenarios that I can think of. Let's say in the situation that the referral comes from the school, and we don't have the consent. We don't have the consent from the mother. We heard a bit earlier Maria talking about stigma within the community. The first thing I would consider, if we don't have the consent, would be to provide, to engage someone from client's background to understand all these aspects around talking about mental illness in that specific community. Obviously, we know that it comes from Sudan, South Sudan. We don't know exactly what ethnic background. Judging on the name, it could be Dinka. So presuming that this is the case, then we engage someone from a Dinka speaking background to understand what's the best way to approach the mother, what's the non-threatening way to basically talk about the concerns that has been presented by the school, ways to engage in a non-invasive way and to use the right words. Maria just spoke a bit earlier about the concepts that we use in the mental health culture that they don't even have, let's say, similar meanings in that specific culture. So I think that's one way to go. Obviously, engagement is and trust are big issues. So I think ways to engage and ways to reassure the mother that we don't disclose details about the family situation within the community. From the description, I understand that there are some concerns around from the mother and disconnects from the community in this context of her children struggling. In the scenario that's, let's say that they would consent and we would have let's say the acceptance to engage someone from their own community. There are different ways to go. One way to engage mental clinicians with clinician with KIMS expertise, to pair with a culture consultant from this specific background, and to go for a comprehensive assessment. There are many unknowns in the picture. We don't know aspects related to pre-migration history. We don't know aspects related to, let's say, the belief system of the mother. We don't know aspects related to previous experience with mental system or any other pre-migration, even in the refugee camp. Other aspects a bicultural consultant could also help us understanding the explanatory model that sits within that culture, as well as ways of, let's say, expressing distress and whether or not that is culturally normative. I think that psychosocial mental health assessment would further inform where to from there. Obviously, like Ulrike said, we can either go to KIMS and to make a further referral if we have enough reasons to consider. We can work with the school together to see what's the best way to engage the family and to support within the school system. There is a program that we have at Transcultural Mental Health Center. It's called Brighter Future, which pretty much helps the new migrants building resilience from within, talking about acculturation, intergeneration conflict, talking about their own identity, and talking about building all this resilience on their cultural strengths. So pretty much in this first instance that we would go.
Thank you very much, Dragos. Maria, I'd like to hear what you have to say. What do you think a book would be feeling as she walks through the door of the surgery for the first time?
I think she will feel very scared. First thing, she doesn't speak English language, so she would not be sure who the interpreter is. She would not be sure about the trust of the information she would give to the doctor, whether it would not get into the community and she gets to be labeled. So there'll be a lot of things going on in her mind, because according to the case study, it's not even her that decided to come to the doctors. It's like she's sent from the school. So I'm very sure she's not even ready. She's not even aware of what she's going to talk about, because it's like a suggestion, and the fact that she doesn't know much about what's going on. So she'll be really scared. And the big thing is the trust about who the interpreter is and whether the information would be confidential.
Absolutely. And what is available within the South Sudanese community that she might be able to tap into that you're aware of?
South Sudanese community is a society that likes to mingle together. If she's a Christian, I would suggest she would have a church group that she goes to. And in every church group in a Sudanese society, there is always a women congregation that have a group, and they meet after some time, maybe once a week or once a fortnight. And if she's not a church-goer person or not a church person or not a Christian, there's also groups within the community where women meet regularly, especially in the weekends. They go and have a place in one of the houses, and they just go, they cook. That person actually cook, and the group will come and they will just talk the whole time. It's always in the evening when there's no school tomorrow, and they could be there up to 12 midnight. So that could be a social support for her.
Thank you. That's really important information, and it's wonderful to have you as part of the G11. During a subsequent appointment with her GP and nurse, Abuk further discloses that she's also having difficulties with her eldest son, Deng, who's now 15. He's not coming home after school, and he's staying late out on weekends. Over the past 6 months, Abuk has not been sleeping well, and she's anxious and worried all the time. She's also developed some paranoid thoughts about some members of her community and is feeling isolated. She's finding it harder to undertake basic caring tasks and lacks motivation, and this is starting to really get her down. This is directed to both Esther and Rebecca. What extra concerns does this raise? And if you haven't explored any specific options for Abuk's own mental health needs, how do you begin the discussion, and where would you even think of referring?
I think to start off, we'd sit down and listen to everything that she's needing to say, everything that she's going through, and then approach it like there are some people, like we've discussed previously. There are people that can support you, where you will be able to sit down and chat with them, and they can go through some different strategies and different options for you to help you through this time in your life.
Thanks, Esther. I'm very aware we have such limited time, and I think that really all my thoughts are actually kind of covered. I think now really reflected beautifully on the way that even though the daughter was presenting initially that you need to be looking at the whole family unit, and I think we're just going to need to be working very, very gradually with this family, finding what services might be most acceptable to them, and just gradually exploring that. And I would have hoped that I might have contacted some of the services and had a bit of a chat, because gosh, if I'd had that chat with you now, that would have been really helpful for me. I would just want to talk to people, I think.
It certainly seems like Abuk has a lot on her plate as a single mother coming out here with 4 children. Is this an appropriate referral to QPASTT, and how would you work with Abuk and her family, and would you refer anywhere else? Is there a role for the psychiatrist? And so this is a question for everyone, really. I'll start with Amy. Is it an appropriate referral to QPASTT?
Yes, again, I think it's an appropriate referral. I mean, I think if we take this case as a whole, I think we'd potentially already be engaged with mum. You know, would like to be, the thought is, particularly with a 7-year-old, you know, it linking mum into that process as well, and hopefully out of that might have come the, you know, the support for her in that relationship, but also individually and then within the family system, or, you know, linking mum in with more, you know, social supports that we might be offering, or try and kind of broaden that within the community as well. So, I mean, I think, yeah, in short, yes, it's acceptable, and then within that, within our process of assessment, we'd refer on as required as well.
Yeah, there's a role for me, of course, but only if it's acceptable to the client. I think there's probably more harm than good done if it's kind of just done as, oh, what you're saying is really abnormal, or you shouldn't be having these thoughts and feelings, or these are symptoms and you may be ill and you need to speak to a psychiatrist. If it's framed that way, it's not going to be helpful from the outset. So, and that's why some refugee dedicated primary care services are very useful, because there's kind of, it's framed in a way that's helpful. There are some things there in the presentation that are a little bit like that first polyuria and weight loss type of thing that makes a psychiatrist's ears prick up a little bit, and then I take a step back and realise that there's lots of assumptions about what paranoid means, because the word in itself brings up little, you need to check this out. And so I will, but it's how the information is only as good as the way that you gather it. So, you know, you do see people in busy emergency departments saying, do you feel paranoid? Do you think people are following you? Are you suicidal? Do you have any plans to take your life? That gives the answers that you get. Yeah, sure, you can tick some boxes of meeting certain diagnoses. I've been talking to you about how that's got very limited utility. What does paranoid actually mean? So, you know, there's some skill in exploring that. Paranoia is normal. Thinking that someone is out to get you is a defence, is a survival mechanism that's been bred into us to get us to survive. And the people who do that the best get to pass on their genes. So, so we do need to explore certain symptoms more, but we need to understand it in context, and we need to get a narrative about that rather than kind of this tick box, this is a symptom and therefore it's an illness type of approach. But it definitely warrants further exploration. Whether a really well-trained GP who the patient's got good rapport with may be the best person to do that. The counsellor who's already working with the client then can talk to me or, you know, a mental health service more about that, or whether I do it directly depends on all of these factors we've mentioned.
Dragos, from your point of view.
There are a few things that probably we need to consider in terms of engagement with the mother. Mixture of feelings that she might experience. Really, quite a recent arrival, 12 months ago. Feelings such as powerlessness, hopelessness, obviously guilt, survival guilt, anything related to, you know, missing family, desperation, unknown. So all of these aspects, all of these feelings, in talking about engagement, a good approach would be obviously to validate and normalize all these feelings. From this point onwards, aspects related to explaining about options that she could have in terms of accessing services. This is what Transcultural could play an important role with. We are a part of linking the community with mental services. As we could see before, mental services representing itself a culture, from diagnosis to navigating system. We could play an important role in assisting with all of this. I think the mother, obviously, herself, she needs support in terms of understanding her own issues and receiving her own support, separate support. Obviously, another aspect would be how, given the fact that they come from collectivistic culture, to identify within the community important persons that she could trust and she could feel comfortable to feel validated as a part of, to avoid isolation, in other words.
And the final question is to you, Maria. I know you've probably touched on a lot of this twice, but it's about what she might think that the community thinks of her with all this support, you know, swimming around her. And is there any way we can enlist the community at all? Or is there anyone else we should be maybe connecting with that isn't part of our panel, is more part of her community?
Yes, as I mentioned before, in the community there would be a lot of support as from the church to the community members. But in this case, the community might be divided because some of them might understand the mental issues and some of them might not understand. So it's up to which group actually would help. And in my understanding, from my church, a lot of people trust the pastor more. And I think it's because they think pastor is a person of God and there's no gossip going around. So sometimes someone would go and talk to the pastor privately about the health issues or anything that is bothering them and that is actually deemed private and confidential. So as I mentioned before, if a book is connected to the church in any way, members from the church, pastor, or if there is any woman leader would be the best point of connection. And if she's not, because not everyone goes to church or a Christian, if she's connected to any other women in the community, in their group, so that is where she could get.
Great, thank you so much.
So thank you very much everyone on the panel, and I think we've got a few minutes for questions. If anyone would like to ask the panel some questions. Anyone? Hello.
Just in regard to the first girl, Rosa, if I would definitely refer to either Amy, Dragos or Ulrike, but I'm not quite sure which one would be best because I would only refer to one service. And secondly, is there a role for referring to more than one of your services within the context of this particular patient, client?
Who would like that question? So Ulrike can answer. Yeah.
I think it was quite interesting to hear this case because we are a group of professionals and we have so much goodwill, so much knowledge and so much resource, but it shows really that we should not overburden our families with appointments, with agencies, and with not knowing what interventions are right at this time. Is there one service? I don't think so, because we are our health system goes by different age. It goes by health, it goes by disability. So I think really the answer is to think multi-systemic, to think systemic, the family as a system and all agencies, and that whoever gets a referral will connect with the other service and that we keep on communicating to be able to deliver our support at the right time so the parents, the family, the child is able to receive. So to your questions, I don't think there is one service. We all will get our referrals, but it's important to communicate and to collaborate. Yeah? Did that answer the question?
Unfortunately, we didn't get to talk about it properly tonight, but on the Refugee Health Network website, there is a link to the mental health pathway, and that's a tool that I do find quite useful. Again, it doesn't answer all the questions, but it kind of, you can kind of step through and look at, you know, whether you've got a child or an adult and what you think is going on, and I sometimes do find that useful. And then I think the other issue is that, as you say, Ulrike, sometimes just picking up the phone and talking to somebody, or if you make the referral and you kind of get it wrong, everybody talks and sort of figures it out, and I think I find that reassuring as well.
Make a slightly related comment, which is sometimes doing this difficult work, we carry around this idea of maybe there's just the right service who'll know just the thing to do, and so what ends up happening is the client gets referred to multiple agencies, but it doesn't get past the assessment phase. They get assessed and they get assessed and they get assessed. So I think it's very important to use every encounter as the potential. You don't need exhaustive information. Most of us have actually very good clinical skills, and we kind of know what to do in a way that's helpful. Usually it's nothing earth-shattering and drastic and life-changing, but you don't need to keep asking more and more and more and more questions so that the patient ends up feeling overwhelmed and helpless. So there's that balance too, I think, and sometimes doing something really simple that they can take away is better than doing a comprehensive assessment with a comprehensive assessment plans. And GPs are awesome at this, just picking up with whatever's occurring and going with it. And so I think that's the other observation I'd like to make.
Thanks. Now, are there any more questions from the audience? Yes.
Hi everyone, my name is Rita and I'm at World Wellness Group. I just wanted to just make a comment, I guess, in terms of another service that is available, which is the Multicultural Psychological Therapies Program. So I noticed on Rebecca's, on your slide, that you had ATAPs up as one of the referral options. And I guess because we're talking about primary mental health care tonight, just wanted to let everyone know that the ATAPs program is currently going through transition, and there is now a new Multicultural Psychological Therapies Program funded through the Brisbane South PHN, which is managed by World Wellness Group. And in fact, the transition arrangements kick in next week. So for all of you here who are from general practices and have been sort of used to the old pathway, and you talked about the mental health sort of talk, I guess all of that sort of needs to be updated now with a new referral pathway. But as of next week, the old referral processes will stay in place until the PHN sort of will make an announcement about the new one. So I guess what I'm saying is you can still access services through the old referral pathway, but actually the service arrangements will be a bit different. And I guess the good news is, picking up on Now's comment about, sort of endless assessments, and we actually need to actually do something, that this is actually a very exciting time to be developing sort of new approaches in psychological therapies with a very strong cultural focus that we'll be undertaking. So just wanted to let people know about that being available. Thanks.
Thank you, Rita. I think we have one more question.
So it's good, each clients are referred to these services, but I'm just concerned of, the waiting period for each referral process, where clients have to wait for 12 months, 1 year, and by the time they reach to their goal, the client is like, why we are here? So it's like the referral process totally lost, and clients is not supported at that period when it's like immediately needed. So what strategies as a service provider or as a psychologist you can put in place for the clients?
I'll just speak from someone who works at the tertiary setting, often in a hospital-based, or, people have been seeing multiple other people before they come to see me. Usually, if you're already involved with the client, as hard as that can feel sometimes, you're probably the best person to support the client. And sometimes it may just be talking to someone who can help you sort of see your way through it or reassure you that you are doing the best thing. I guess it all comes from this notion that things have got to get to a certain state. Like, here's where the client is, and we want the client to not feel this, not suffer from this anymore, this to go away and be over here. And it just can't happen soon enough. But I guess that what we're dealing with a lot of the time is about experiences people have been through, and this is human suffering that you can't solve, that you can't fix. And one of the things you can do to help is hang in there and just stay with the client. There's also an effect called the waiting group effect. There's lots of trials at the moment. People get put on a waiting group, something happens and they're a little bit better. And that's about hope. And that's about the person feeling sort of more empowered, or like something can change. So I don't know if that answers your question. Yes, there are certain different services with different sort of time waiting period. And sometimes picking up the phone, this is how we all work. It can help that referral occur a little bit sooner. Yeah.
I just wanted to add, because I know how you feel. And I guess, I completely agree with Nya. Again, I just think keeping that regular contact with your patient is really important. But also I think then kind of engaging whatever other supports are possible is really important. So I think, what Maria was talking about in terms of what's available through the community and what the patient can identify themselves as being supports is really important. And I find that often you can do a lot in that space. And I've run QPASTT before and gone like, oh, my patient's just been on waiting. And, there's homework club and, basketball groups and family groups and all of those things that you can kind of get in place while you're waiting, I find helpful.
Okay, well, I think one more question and then I think we're done.
Just one observation is that what seems to be starting to happen more frequently is that some people are actually being over-serviced, and then we have other people who are just waiting and waiting. So, somebody may be referred to a psychologist through ATAPS. In the meantime, the school refers the family to QPASTT, and then somebody else will refer them to QPASTT. And then they might land up in emergency over the weekend, and transcultural mental health is involved as well. So that's really a difficult problem. And often there are a number of stakeholders involved, so a case manager might be involved. It's very, very difficult to try and tease out what's going to how things are going to go forward from there. So I'm wondering if there would be any way that people can think about how we could streamline things so this doesn't really happen. I've had one family that had no fewer than 8 organisations involved, and nobody was talking to each other, about what they were doing. The other thing is, for Amy, would it be possible for us to get reports on clients that have been referred to QPASTT? Do you already do that? Because, just wondering if we can. Thank you.
Sure. Do you want me to answer the last question first? Let's start there. So I guess routinely we don't, at a certain period write reports and do that, but it is definitely something we provide. So we will often get sort of requests from certain departments or certain people to sort of have. And it's in varying degrees as well. Is it more of an update around sort of how are things progressing, or is it more of that psychosocial report of how things, what's part of our assessment to how things are progressing along? So, it's definitely something we often do, and we're often writing reports, but it's more of that request coming through, definitely. Yep.
It just would be good if GPs could possibly routinely get reports, because often GPs don't know that their patients are actually going to QPASTT. So, yeah, and other agencies as well. So if there's any way that you could actually ask the client, you know, who the GP is, and then make contact with them and sort of liaise and report, please.
Yeah, definitely. Look, I mean, I think it's one of those things, though, often our clients might have 3 or 4 different GPs, and some they'll go to just for mental health, or some they'll go to just for sort of physical, and so I guess it's as well about getting their consent to sort of be sharing that information, or who is the right GP that they want this information going to as well. So, I mean, routinely as part of our assessment process is trying to work out who is involved in your care, and then there is as much as possible that connection, that collaboration, because it's really important to get the GP's input as well. And so I think if that connection can happen, then there can be more of a routine established with that service provider as well, I think. Definitely. Yep. Yeah, of course.
People should take the microphone off me. But I just want to say, I at one stage as a GP was working at a practice in Inala called Inala Primary Care, and also working at the Refugee Health Clinic at the Mater. And I actually had a patient referred to me at the Mater by a caseworker who said, you know, that they're seeing this GP, but like they haven't seen them for ages, and they haven't. And I'd seen this. I was the GP. I'd seen them last week, and I think sometimes what can happen is that again, just because, you know, this can be a really vulnerable population, and there's lots of complexities, and people do often just go to lots of different places to seek answers. I mean, sure, I think we do need to have systemic change that does allow for, you know, to avoid these issues where people seeing multiple different providers. But again, my first reaction to this case, where it was just talk to each other, basically, I think still stands whenever you get a chance. And I know that's hard in general practice, you don't have time, but just talking to each other, I think, is a big part of the answer. Yeah.
Giving the client a letter, giving them possession of it, and you shouldn't be really writing anything in reports that the client, you wouldn't be, my general rule is if I'm going to write a report, there shouldn't be anything in there that the client will see and disagree with, otherwise I need to discuss that with the client. Back to your duplication of services, I think that's partly because what we operate on is risk. When certain risks are identified, everybody jumps, and yet they aren't the best predictors of who's going to benefit from treatment. Unfortunately, we have this disparity. So I think that's often the reason why there's 4 or 5 services involved in that quick referral, and, you know, multiple members are seen. It's hard to change that culture. It's about the stuff in the background of what makes something a good referral. So I don't have any quick fixes to that.